Thank you, Mr. Chairman, esteemed DP colleagues, ladies and gentlemen. Good morning. I have been given the task to talk about the role of implantable cardiac devices in the management of atrial fibrillation. So this is a brief outline. I will talk about the role of devices in detection of subclinical AF, what is the incidence and prevalence of device-detected AF, and do they have any role in the prevention and treatment of AF? And we are talking a lot about AHREs and device-detected AF. And what is the role of implanted devices in the evaluation of cryptogenic stroke? And I will briefly touch upon the guidelines. So regarding the subclinical and device-detected AF, each year about 17 million people worldwide have a stroke, and the cause of which remains unexplained in 20 to 40% of the cases. So among these unexplained strokes, 10 to 30% may be caused by atrial fibrillation that has eluded detection. So widespread use of cardiac devices has led to the detection of subclinical AF in a substantial proportion of patients. So there is evidence that these asymptomatic arrhythmias are associated with increased risk of stroke. Thus, the detection of subclinical AF may offer an opportunity to reduce the stroke risk by initiating anticoagulation. So we have a plethora of devices, both wearable and implantable, which are helping us in detecting this entity. So we have millions of patients worldwide who already have an implanted device, or we go up front and implant the loop recorders or ICMs to evaluate the subclinical or suspected or undiagnosed AF. And the data transmitted is very helpful and pretty straightforward to interpret. So this is the epidemiology of subclinical AF. This is the review of 54 studies. So you can see the prevalence is very high, 28.1% of patients across these studies. And so it correlates with mean age, expected mean age, ADSVASC, and prevalence of comorbidities were associated with subclinical AFib. And the incidence is a lot. So almost everybody. So this is ranging from 28 to 68%. So we have if we have so many patients coming to us, they have the implanted devices. So we should be on a lookout. Each and every patient who comes for a clinic visit should be looked for. So in most of these studies, it ranged from 28 to 68%, and with time, the incidence increases. So what we are looking at, the clinical AF, is probably the tip of the iceberg. And the undetected or subclinical AFib is probably unknown, and we still don't know how to screen for it. And yesterday there was a talk, and we still don't have the consensus. So this entity can be an incidental finding on implanted or wearable devices, or an incidental finding during monitoring for other cause, or it can be detected during evaluation for unknown stroke. But on the other hand, we don't know yet what is its impact and what is the burden and how to manage it. And there are some false positives which can be seen. So this is the pooled analysis of 3 prospective studies which showed that longer the initial episode of subclinical AFib, longer initial episodes of subclinical AFib were associated with the development of atrial fibrillation lasting for more than 20. So shorter the duration and shorter the chance that it will be converted into a clinically apparent AFib. So this was a landmark trial published in 2012. They took 2,580 patients who already had, most of them had pacemakers, some had defibrillators. And there was a run-in period of 3 months, and 10.1% of patients with different atrial tachyarrhythmias were enrolled, and there was a definite association of stroke in these patients. So the same study was, this was the post-hoc analysis, and they took the same cohort and followed them up for 5 years. And they saw that the stroke risk in these people was the same, probably stroke risk for an AF of a 24 or more than 24-hour duration was comparable to a traditionally detected AFib. So what about the cryptogenic stroke? As I said, 25 to 30% of ischemic strokes remain cryptogenic after standard stroke evaluation. A large proportion of these events are presumed to be related to occult AF. And as long as we do not have the documentation of AFib, we have to give them antiplatelets. Now, AFib needs to be detected, which is unknown, and so that our treatment modalities change. And this was the landmark Crystal AFib study, where cryptogenic strokes were either given an implantable loop recorder versus a conventional follow-up ECGs. And you can see the yield was very high. At 6 months, 8.9%. At 12 months, it was 12.4%. And the same group, when they were followed for 3 years, the yield increased to 30%, which is a lot. Now, another similar study published in JAMA called a per diem study, which compared the role of loop recorders to those of external loop recorder versus an implantable loop recorder. So the significantly greater proportion of patients with AF detected at 1 year with ICMs was seen. Now, the guidelines say that if you already have a patient who has a pacemaker or an implantable defibrillator, it's class 1 indication to look for atrial high rate episodes. Now, the recent guidelines gave it a class 2A status in patients with stroke or TI of undetermined cause. Initial cardiac monitoring and, if needed, extended monitoring with an ICM are reasonable to improve the detection of AFib. Now, do these devices have any role in the prevention and treatment of AFib? We know that in patients with pacemakers, programming strategies to reduce RV pacing might reduce the incidence of AF. Devices that maintain AV synchrony reduce the incidence and progression of AF. Although maintenance of AV synchrony is important, the analysis of the landmark MOST study and a meta-analysis have demonstrated that the amount of ventricular pacing is an important contributor to the development of AFib. So these were landmark trials for bradycardia pacemakers, and the results were mixed. And most of these were 6NS syndrome, except the UK PACE trial, which was for the high-grade AV blocks. So most of them showed that atrial pacing, preferential atrial pacing resulted in a significantly lower rates of atrial fibrillation and thromboembolic events. So the UK PACE was, on the other hand, a randomized study that evaluated patients with AV block and who were very old, more than 70 years of age, and required a pacemaker. The dual chamber pacing did not reduce the incidence of AF compared with single chamber ventricular pacing. Now, what about the maintenance of AV synchrony? So we are, when we can, we should try to minimize the percentage of ventricular pacing. And one of the algorithms in some devices is called managed ventricular pacing. And the SAVE PACE trial showed that dual chamber pacing with minimized ventricular pacing compared to a conventional dual chamber pacing showed that the proportion of patients was lesser. Proportion of patients without persistent AFib was lesser when we used this particular modality. And similarly, the interventions for different interventions for stroke was less when we used dual chamber pacing with a feature of minimized ventricular pacing. So what about the atrial pacing interventions for the prevention and treatment of AF? Pacing algorithms designed to suppress atrial ectopy were not able to successfully reduce atrial fibrillation in randomized controlled trials. Several studies have reported that specialized anti-tachycardia pacing algorithms can terminate atrial tachyarrhythmias, but have not reduced the AF burden. However, in a post-hoc analysis of a subset of patients who had high success rate of anti-tachycardia atrial pacing, anti-tachycardia pacing algorithms reduced the overall AT AF burden from 2.5 to a mean of 0.68 hours per day. So this was a study, Minerva study, which compared a conventional DDDR to an MVP mode or to an to DDDRP. This is the anti-tachycardia pacing, anti-tachycardia atrial pacing, plus MVP. And they showed that the incidence of persistent or permanent AFib was lesser in the subgroup patients who used the DDDRP plus MVP mode high efficacy ATP. What about the conduction? This is the new kid on the block. Conduction system pacing, we are still in the initial phase of learning this. But early non-randomized studies have suggested that his bundle and left bundle pacing may reduce the AF incidence and progression when compared with RV pacing in patients with high burden ventricular pacing. Left bundle branch area pacing reduced the incidence of new AF when compared with RV pacing, but this benefit was evident only in patients with ventricular pacing of more than 20%. So this study showed that this is in red. You see this is the conventional RV pacing with high percentage of ventricular pacing compared to the left bundle branch area pacing. So the incidence of new onset atrial fibrillation was significantly lower with the conduction system pacing. So the guidelines say that in patients with bradycardia requiring cardiac devices who have normal AV conduction, device selection and programming strategies to maintain AV synchrony and minimize ventricular pacing should be used to reduce the incidence and progression of AF, and this is the class of recommendation 1 with the level of evidence A. So 2B recommendation for patients with a pacemaker and symptomatic atrial tachyarrhythmias, anti-tachycardia atrial pacing and ventricular minimization may be useful for reducing symptoms. Similarly, the conduction system pacing also got a 2B recommendation, while as there is no benefit of using specialized atrial pacing algorithms. Now, these are the atrial high rate episodes, and we know that some of these patients are at a high risk of stroke, especially the episodes which last more than 24 hours. And there is, by contrast, short episodes, commonly defined as less than 5 minutes, are not associated with clinical events. So patients with episodes of intermediate duration and elevated stroke risk may benefit from oral anticoagulation. Both AHRE duration and CHA2DS2-VASc score has to be taken into account before initiating any anticoagulation. So this is the 2A recommendation. If you have an AHRE lasting for more than 24 hours with a CHA2DS2-VASc score of 2, you may initiate anticoagulation. While as if it is between 5 to 24 hours, but the CHA2DS2-VASc score is more than 3, there's still a 2B indication for anticoagulation. But no benefit of giving anticoagulation to people who have very brief episodes of AHREs. So how to deal with them? Subclinical AFib and AHRE burden. You have to see what is the burden, and you have to see the patient risk. So if the AHRE is more than 24 hours and the patient is at high risk, it's a straightforward case of anticoagulation. But shorter duration, less burden, so we can probably wait and assess it further. These were 2 trials, Artesia trial published recently, which clearly showed that subclinical AFib is associated with an increased risk of stroke, and apixaban was compared to aspirin, and apixaban showed there was a reduced stroke risk in patients with subclinical AFib. At the same time, we had this NOAA-AFNet 6 study, which was a negative study. So any patient with the AHRE lasting between 5 minutes to 24 hours, there is no benefit of giving edoxaban. So it was the same as compared to the placebo. So what about the remote monitoring? Remote monitoring has probably a huge scope to monitor these patients and at the same time decrease the hospital burden in terms of patient visits. So it can help us in atrial fibrillation detection. CIEDs facilitates the early AF detection and quantification and calculates the atrial AF burden. That is particularly meaningful for asymptomatic or silent AF, What is the beauty of this modality? That it detects the atrial fibrillation early. Okay, on an average 1 to 5 months earlier with remote monitoring versus conventional follow-up, which is a lot. Remote monitoring has a sensitivity of nearly 95% for true AF detection, and approximately 90% of episodes that trigger alerts are asymptomatic, and early AF detection promises earlier treatment, potentially preventing adverse events such as stroke or inappropriate shocks and heart failure. So it can tell us exactly about the trends and the total burden, and especially, for example, in patients with predominantly nocturnal or daytime onset of AF episodes, they had less associated comorbidities and less atrial fibrillation progression compared to that patients with mixed onset AF. So, and the programming will help us. So any AFib detected by a device need not be, reported, or the alarms can be, modified. So in permanent AF, for example, all alerts should be switched off and only ventricular rate should be monitored. Now, there is evidence that event-free survival is better in patients with remote monitoring devices compared with conventional care. And you can see that this reduces 81% reduction in the unnecessary clinic visits. So obviously it is not only meant for atrial fibrillation, it is meant for all the arrhythmias and events monitored remotely. What about inappropriate ICD shocks? We know that atrial fibrillation is a common cause of inappropriate ICD shocks, contributing to morbidity. So we can take help of the devices and appropriately program them to reduce these inappropriate shocks. Now, about just the last couple of slides regarding AV nodal ablation. So in permanent AF, when we are not able to control the ventricular rate, after we do the AV nodal ablation, initial pacemaker rate should be in the range of 80 to 90 beats per minute to reduce the risk of sudden death. So 2A recommendation in patients with AF and uncontrolled rapid ventricular response refractory to rate controlled medications who are not candidates for or in whom the rhythm control has been unsuccessful, AV nodal ablation can be successfully can be done to improve the symptoms and quality of life. So in patients with AFib who are planned to undergo AV nodal ablation, the implantation of a pacemaker should be done beforehand to assess the efficacy and adequacy of pacing leads before performing ablation. And thank you very much.